want it to finish.
No, maybe it is continued. Anyway, Dr. Gulshan, we are going live. 2 minutes we are just taking as a break, and then we'll give the cue to Aman. He'll introduce you, Dr. Kasper, and we'll start.
No, I meant I didn't want. We started already? No, we didn't, right?
No, we haven't yet. 2 more minutes to go, right, Dr. Manish?
Yeah, 2 more minutes, but yeah, we'll just be on mute for some time till 5:30.
Okay,
Okay,
perfect.
fine.
Aman, you're good to go.
Yeah, good evening, everyone. I hereby welcome you all, and we take a great pride and pleasure in bringing you the ninth series of the educational program, Advanced Classes in Dentistry. This program shall be conducted with our esteemed speaker, Dr. Hussain S. Basma. This educational program is brought to you by FDC Limited, makers of flemiclav. Therefore, on behalf of FDC Proxima, greetings to everyone. I now request Dr. Basma to enlighten us on the topic of prosthetic consideration for final prosthesis in full arch cases.
Sure. Thank you so much, Aman. Thank you, Dr. Gulshan. Thank you, Dr. Varma, for your always for this amazing series, actually. I would like to start also by thanking all of the attendees for being here today. Today is the 9th lectures in this series, and the topic was supposed to be guided bone regeneration, but due to certain technical problems, we have to switch the topic from guided bone regeneration into prosthetic consideration for final prosthesis in full arch cases. And so basically what we're going to cover this afternoon or this evening is related to taking the impression after you place the implant in full arch cases. What are the considerations that we should take in order to make sure we avoid any complications from happening and we maintain longevity of the prosthesis in such cases? So if we look at the overview of the process for full arch cases, we all agree that any surgical or any treatment modality that's related to implant placement has to start by pre-surgical treatment planning, which is basically the prosthetic planning that starts with the diagnostic data, that starts with gathering all the information, with data acquisition, with having a 3D X-ray, and then definitely having something called the duplication of the prosthesis, which in some cases it's called the radiographic guide. That is going to be the reference where the teeth are, and that's going to help in the evaluation of the CBCT, in understanding what's the space that you have on that in that case. And definitely based on that, we can fabricate a guide. It depends if you are going to go with a guided or versus analog type of treatment or surgical steps or prosthetic steps. And then we end up with fabrication, this surgical guide that's going to be our guide during implant placement. And whenever we're doing our implant placement, we have to respect the biology. We have to respect also the prosthetic considerations that we should, that guide that we already created in the pre-surgical treatment plan, that is going to guide us where the implant placement, where the implant is going to go. It's going to guide us where, how much reduction of bone we are going to make. And then we place our multi-unit abutment after we place our implants, depending on the AP spread that we're going to talk about in just a little bit. Once we do that, we have adequate stability. We move into the conversion step, if we have, which is, that's why we're doing immediate loading in most of these cases, depending on the cross arch stability of those implants. So basically, when we do this, we do the pickup of the denture that we already have. That's why it's very important for this denture to be accurate, to be well made and well fabricated, actually. And then we do the conversion in the lab. We make sure that we have respected the contact points, and then make sure we avoided any cantilever at that time. And we have given the patient good instructions. And then we move into the last step, which is the prosthetics step, which is basically that we're going to be talking about this this afternoon or this evening. So whenever we are done with the, actually with the, so our lecture actually today is going to be focusing on, after the implants already healed, when you place them, what are the steps that you should go? We are going to talk about like the initial impression, the master impression, the verification jig, the teeth try-in, the fabrication of the bar and the MMA, and then the final teeth setup and the delivery of the prosthesis. So let's talk a little bit about some literature review on this topic. If we look at this retrospective study by Choukilidakis, actually he found that the most common complication that happens is basically the loss of access hole material, which is when you seal that screw access with telio or with composite or whatever material. This is one of the highest complication that could happen, and this is usually an easy fix. And if we look at the second or the most common complication that we can have is a major wear of the prosthetic material. So we have to understand that this in addition to that, we have multiple reasons why dentures could fail, but literature have shown us that we have a cumulative survival rate of these type of prostheses in 88% at 3.5 years if they are done in if all the biology, if all the prosthetic considerations were taken into consideration. And there is definitely no difference in the survival rate or the patient satisfaction, whether it is a metal resin, full metal resin prosthesis or versus a metal ceramic prosthesis. And as I mentioned earlier, the most common complication at 10 years was the loss of the screw of the hole material. And the major complication was the wear of the prosthetic material. So we have to understand what's the antagonist of the arch that we're dealing with. Should we do zirconia versus acrylic? Should we do zirconia versus zirconia? So it's always very important to plan that prior to execution in such cases. And definitely there is and a significant increase in the prosthetic complication if the opposing implant fixed prosthesis was compared to a removable prosthesis, because here we know that the patient will lack proprioception, his biting forces are higher. So basically we have to do something which can lead to decreasing the forces, such as fabricating an occlusal guard in such cases. So this is a patient that presented with this kind of prosthesis. And when we look at the frontal maximum intercuspation, we see that there is not ideal gingival height. And there is also, we can tell that in such prosthesis, there's a minimal space that we are going to have in order to fabricate such a prosthesis. And that's why we're having some complications as a fracture line in those areas, in addition to the lack of adequate occlusal scheme in such cases. in such a case, and that will usually lead to major complications. And restorative space is always a big deal, and this has to be planned prior to surgical execution. Why? Because if you place your implants and now you have lack of adequate restorative space, what's going to happen is that it's too late right now. You're going to end up with a compromise. You're going to end up with complications. So you have to plan that early on whenever you're trying to fabricate your initial prosthesis, and that's going to be your guide in the surgery to know how much reduction you're going to do in the alveolar prosthesis. So based on that guide, we have to know how much space, and prior to that, we have to understand what's the surgical or what's the prosthetic design we're going to end up with, and we agree on with the patient, because as we will see in just a little bit, every prosthetic design will have a different restorative space recommendation. So if we have lack of adequate restorative space, what we're going to end up with, we're going to end up with a weak prosthetic rehabilitation. We're going to end up with a poor physiological contours, inadequate aesthetics, because we're going to try to accept a compromise in this situation. We don't have good emergence for the prosthesis. We're going to have a reduced interocclusal space. That means limited amount of prosthetic material that we have. And then the most common thing is that we're going to have a fracture of the prosthesis. And if you already do full arch cases, and every time you do place an implant, you give the patient a temporary or you do the conversion, the patient comes back, as you see in this picture right here, that means most of the time the patient doesn't have adequate restorative space. And again, as I mentioned earlier, depending on the type of prosthesis, you have to understand that from the beginning, or you have to plan that from the beginning, so you can base your surgery on these types of prostheses. Let's say for the bar overdenture, you have at least a minimum height or vertical space of 11 millimeter. For a fixed screw retain hybrid, that means you have to have at least 15 millimeter of vertical or interocclusal space or restorative space. And when we say, for example, in this case, the fixed screw retain hybrid, you need 15 millimeter. That doesn't mean you have to place your implant at 15 millimeter. No, it doesn't. Why? Because if you look at this prosthesis, which is a metal acrylic prosthesis here, most of the time, it's not only the 15 millimeter that we talk about. It's basically the 18 millimeter that we have to have in order to place the implant. Because as we mentioned in the earlier table, we should have 15 millimeter for the prosthesis. And that restorative space is calculated actually from the gingival margin all the way to the incisal edge of the prosthesis. Or when we are calculating this, we have to measure that from the position of from the margin of the multi-unit abutment to the incisal edge. And it's very important to respect that. Again, those numbers are golden. We don't have to mess with, because if you don't respect these, you're going to end up with a great or with a poor prosthesis and with a lot of complications. So if it's a zirconia prosthesis, for example, you can place you need a space requirement around 12 millimeters, so you can place your implant at 15. And when we say 12 and 15 is basically the difference between the implant level and the multi-unit abutment level, and that's basically where the soft tissue component is located. So it's very important to assess that before we place our implants. We have to keep in mind also that we don't only have vertical component, we also have sometimes some horizontal component that we should always keep in mind also. So it's very important to understand the anatomy of the jaw that you're dealing with, and you plan your implants based on the design and the prosthesis that you already fabricated. So let's say this is a patient that had implants placed, and then the patient presented actually after 3 months of healing, or after 3 months after implant placement. So now we remove the temporary prosthesis here, the temporary prosthesis, and now we're going to do what? We're going to take an impression. And keep in mind here, in this case, we have some implants that are very angled buccally. And in such cases, as you will see right here, we have a straight multi-unit abutment, which is a thing that we can avoid by simply having or by simply placing or replacing those multi-unit abutment with angled one to make sure that the axis is moved more palatally to avoid weakening the buccal porcelain, and that's going to be prominent to fracture or chipping. So in these cases, we have to basically keep an eye on those two implants right here, and we have to understand that most of the time in these full arch cases, personally, I prefer to create something like this, what we see in red right here. This is called the verification jig. And when we talk about verification jig, it's basically trying to limit the amount of flexure that or after the material is setting whenever we're taking an impression for full arch cases. So splinting impression actually minimizes the movement and rotation of the coping during an impression, making removal, attachment of analogs, and then pouring during the impression, removal the analogs, and at the time of pouring. So in this case, we placed our, as you see right here, as you saw right here, I'm sorry, just give me a second to go back. So as you saw earlier, in this case, what we were trying to do here is we were trying to take an impression for this case. Again, we have to fabricate a verification jig. You can do that analog and digital. You can use various material. Personally, what I like to create this outside the patient's mouth and then connect those, as you see in between those impression coping, connect them inside the patient's mouth right here. And why? To minimize the amount of shrinkage that could happen after the setting of the material. So we took an impression here. When we take an impression, we put an analog, and now after we place an analog, we make a soft tissue moulage. And I always personally do not like to splint the soft tissue moulage, just in case you need to process into the master cast. And this is actually evidence-based literature that showed that it's always better not to splint all the way, just in case you need to process into the master cast. So definitely for this impression, what we like to use is PVS, or we can do it digitally these days. Okay, we do a bordered molding final impression in case the treatment plan is altered from a removable prosthesis at the time of the try-in. But this means that you didn't do the adequate planning from the beginning. So it doesn't matter actually at that time. So it's always very important that you have to create this customized tray. And this customized tray, before you take the impression, will help you provide a uniform thickness, making it superior and more appropriate than the stock trays. Also, it's more accurate impression when full arch impressions are made. And you can actually check if you want to use an open tray versus a closed tray, depending actually how many implants you have. Okay, for more than 3 implants, the direct technique is always more accurate. So after we take the impression, after we put the moulage, we have to make sure before we take the impression that the verification jig is seated all the way. Or after we pour that impression, we get another verification jig, and that verification jig has to have a passive fit. And when we talk about passive fit, is that, and that's how you make sure your impression was successful. So think about it this way: after you remove your temporary provisional, or the provisional that you already converted at the time of implant placement, 3 months after that, you remove this temporary prosthesis, you put the impression coping, you fabricate a verification jig, you fabricate a custom impression tray, you take an impression using polyvinyl siloxane. Now you place the soft tissue moulage, and then you take the impression. Now you want to make sure your impression was very accurate. So what do you do in this case? Basically, you do another verification jig, and that verification jig has to have something called a passive fit. When we talk about passive fit, we are talking about possible complication that could happen if we don't check the step. Okay, so if it was within a tolerable range, there are no clinical complication. However, if there was there is like an active fit here, and doesn't have a passive fit, we might end up with marginal bone loss around the implants because you're putting a lot of strain actually on some of the implants. Also, we might end up with failure of the implants. We might end up with prosthetic complications such as loosening of the screw and such as loosening and fracturing of the screw and fracturing of the implant component. So it's very important that we have to respect this passive fit. So basically, when you created this passive fit, we have to check how to do this passive fit. We have different techniques. We have the alternative finger pressure, where you evaluate rocking of the prosthesis and see if it's rocking. If it's rocking, that means that your impression was not very accurate. Or you can do direct vision by using the probe on one side, by using the pressing on one side and using the probe or on the other side. Radiographs also is another option that we can see, but what I like the most is the Sheffield test. And this is basically, you put one screw tightened at one end, and this whole prosthesis or this whole verification jig has to be seated with a passive fit all the way around. And then we have other tests that we can check, but the Sheffield test is actually my go-to. I like to use more than one, or I like to combine these methods just to make sure I'm very accurate. Like let's show. So basically, if you want to show you an example of the passive fit, if you look at this case right here. Here I placed a one cover screw on one side, or I was able to screw this impression coping on one side and see how it's open on the other side. Why? Because I don't have a passive fit, because my verification jig is not very accurate in here. So basically, we have to make sure that we have a good passive fit all the way around, and we are trying to record this the implants in the accurate positions. So in some cases, we can just go custom. We can just be creative whenever we're taking this verification jig. If we felt that one of the implants is not seated all the way, we can recorrect that in the model cast. Or in some cases, you can say, you know what, I don't want to take any risk. I want to take a whole new impression. In this cases, we just altered the model that we have, and then we redid another verification jig to make sure our impression or our impression is now more accurate, and it has a more reliable prosthesis with less passive, with a better passive fit for sure. Whenever we take the impression right now, we move into the centric relation. It has to be repeatable, it has to be precise, and it has to be stable in healthy. It should lead to a stable in health. It should be stable in healthy joints. Actually, we made like an occluser wax rim, and this wax rim has to be screw retained on 1 or 2 or 3, depending on how many you want those implants. So basically, we move this in the patient's mouth, and we try to fabricate the MMR, which is basically in the centric relation. Once we have this MMR, we can then have a teeth setup, and most of the time we recommend using nano hybrid composites. They are very high teeth, that they have a high resistance to wear, they have high resistance to plaque buildup, and they have a very aesthetic appearance. We have different shades that we can ask the patient to if they agree with, what kind of shade they would like to have. But what's more important is that we have to always keep in mind the implant-supported restoration have been shown to exert higher masticatory forces than patients with tissue-supported denture. And why? Because those patients, we removed all the PDLs, or we removed all the teeth. Now they lack proprioception. So the heightened forces may lead to an increase in the chipping in the composite teeth. So it's always indicated that PMMA-based denture teeth for these patients should be used. And those teeth are less prone to chipping, but definitely have a higher wear than composite teeth. So then after that, we deliver the final prosthesis. And now, after we deliver the final prosthesis, we have to make sure that we are adjusting the bite, and we have two options actually. We have either we go with an anterior or canine guidance, where the posterior teeth are protected from tooth to tooth abrasive wear, and then this canine guidance will reduce harmful lateral forces and damaging effects of the fara function. Or we can go with the contact posterior anterior in maximum. Also, we have to have a maximum intercuspation, and this will protect the joints surrounding surrounding structures by reducing the percentage of absorbed forces. And this is very important that we kind of adjust the bite and make sure that it's well positioned actually. And then we want to make sure that depending on every position and we don't have any high contact points, because that might lead to some serious issues in the porcelain, in the material that we're using. So it's very important that we have to keep in mind what's the type of occlusal schema, what we want to use when we are using it. Okay, so we have the canine guidance, we have the group function. Usually the canine guidance have a high stress values on the alveolar bone according to the neck region or around the neck region of the implants in the cortical bone. The group function, the highest stress values are on the implants occurred at the neck regions of the implants. It could be bilaterally balanced, lingualized, or monoplane. So basically, after we adjust the occlusion, it's very important that we have to keep in mind, okay, the type of occlusion that we have to use in those cases. Okay, so we have to have a balanced occlusion all the way around the prosthesis. And usually part of this prosthesis, as we mentioned, is the bar that is going to, especially if we're using the metal acrylic restorations. And in those cases, we have different types of bar designs that we could use. In the mandibular prosthesis, we have to have a hygienic design. Aesthetic is not a big issue in the mandible. So that's why we have to have a prosthesis that's going to make it easier for the patient to clean. For the maxillary prosthesis, we have to have an aesthetic design. We cannot afford any gaps between the prosthesis and the tissue, because that can lead to phonetic and some aesthetic problems in some cases. So basically, what we want to create, to understand, are the different types of bar designs that we could fabricate depending on the type of or the position or the location of that jaw. So for example, for maxillary bar design, we have to make sure that it is aesthetic. For a mandibular bar design, we have to make sure that it is hygienic. It's easier for the patient, even though the maxilla we will see how we can create some points that allows the patients an access those locations in order for us to clean it really well. So the bar design, we have the wraparound bar, we have the Montreal bar that can be used for in those hybrid conditions. We have the Dudler, we have the milk bar, we have the Hader bar. So we have different types of bars that we can use. But again, the most common ones is the wraparound. And now we're switching down the maxilla. For the mandible, we have just to go back. For the mandible, we have the hygienic bar, which is basically the one that you'll see in just a little bit on the right side right here. So the maxillary wraparound bar, you'll see how does it look. For the mandibular Montreal bar is the one that we said it's hygienic. This allows to have a metallic part underneath it that makes it easier, less plaque retentive. So so it's very important for three things right now that we talked about. The restorative space based on the initial plan, this is very important. The occlusal schema, and definitely the verification jig whenever we're talking about this. Also, one of the important things that we should always keep in mind during our implant placement is something called the AP spread, which is basically the anterior-posterior spread, which is the distance between the line connecting the distal most distal implants and the center of the most anterior implants. And usually this space, we multiply it by 1.5, and usually that is how much cantilever we can place behind those implants. And again, this has to be planned prior to implant placement. It is always a problem when we're dealing with a U-shaped mandible, and it's always more favorable when we have a V-shaped mandible because that allows for a larger AP spread. The problem with having a smaller AP spread that we put a lot of forces on the most distal implant. Actually, a lot of compressive forces on those most distal implants, the A and D, as you see in those images, and a lot of tension forces on the C, which is the middle one. Think about the rocking that we have in these cases. So the AP spread has to be thought about from the beginning, because if we have smaller forces, what could happen, that could lead to some of the problems at this site that you see on the fulcrum of the connector of the terminal abutment, and that's where most of the fracture would really happen. So we have to understand that an adequate, one of the best prostheses is whenever we have a maximum AP spread with minimal amount of cantilever. That's going to reduce the forces and makes us having a shorter type of cantilever. That's why in some cases now we have the pterygoid implants to avoid such a cantilever and have a full supported prosthesis. So it's always very important to make sure that those cantilevers should be thought about from the beginning. Okay, most of the time, because of the anatomy, sometimes in the side we have to angle our implants or tilt our implants in order to avoid the anatomical structures such as the maxillary sinus or the mandibular IAN. And based on the physiological resorption that could happen, generally we can avoid that by tilting our implants in order to maximize the AP spread that we could have. So by increasing the AP spreads or decreasing or if we have an increased cantilever, we will have stress on the prosthesis. We can end up with fracture the prosthesis. We can have a screw loosening of the middle implant that we talked about. The screw can fracture, the implant could fracture. We could have some bone loss around the implants. So it's always very important to keep those three things, the biomechanics in mind, okay, the AP spread and the bone quality, especially the maxilla versus the mandible. We all know the type of bone. We have a D3, D4 type of bone most of the time in the maxilla, D1, D2 type of bone in the mandible. So it's always more favorable to place such kind of cases in the mandible due to the different or to a better bone quality. The distribution of the implant is always very important for the AP spread, for having a better distribution of forces. The prosthesis design is always important. The prosthesis material also is very important to limit the amount of plaque, to have a stronger structure or more prone to or more or less prominent to wear actually, and that to occlusal forces. To go back, the maxillary wraparound bar, this is what we use in the maxilla, the mandible wraparound. And now when we are checking this bar, we have to place it in the mouth. We do the same thing. We will put the Sheffield test, one screw on one side, and the whole prosthesis should be fit well. If there is any misfit in those cases, then we have to take the impression again. But at this time, it's too late because this bar is kind of expensive. We already spent some time on, so we have to make sure that this bar at this point we have a passive fit. Then, based on that, we have to measure the restorative space, and at this point we have to have kind of a model that will help us. So that's why in some cases what we like to use, we take we do a wax up in those cases and try to see how much space that we have, and then based on that wax up, that's what we're going to be trying in the patient's mouth. And then to check the MMR, to do whatever based on the MMR that we already created. And here what we have to do is basically, when we're setting the tooth, we take kind of a model to help with the teeth setup on the bars. And this is usually what's created on as a final prosthesis. We make sure that things are looking well, that the bar is hygienic, that we don't have any concavities on the intaglio surface. everything is well polished, everything is the finish line for festooning if we need it. We don't have any sharp corners, and then we don't have any concavities in the intalus surface. So make sure that we have those sites are the highest. We make sure that we have minimal screw access hole whenever we're doing this. So once we finish with that, we will definitely start making sure that the prosthesis at the end is not going to harbor any plaque. We don't have any areas that are going to be harder for the patients to clean, as you see in this image right here. Once we already adjusted all the things that in order for us to have ideal final prosthesis, then we move into processing the hybrids by following or sending it to the lab. The lab is going to flask the final the waxer that we already have. They flask it, they boil it, and then they put the priming bars, and then based on that we do the final prosthesis. So it's a kind of a process to go through it, and the whole thing is to show you here that what we want to end up with is a hygienic, easier prosthesis in the mandible, and a well or aesthetic prosthesis in the maxilla that's also easier for the patient to clean. So now it's just a matter of creating access, opening the screw access channels, and in this final prosthesis, and then we end up with a metal acrylic prosthesis. Again, here we're trying to limit the amount of material that we have to remove whenever we're finalizing these bars. Now we have finished hybrids that are mounted, and now we move these hybrids into the patient's mouth, making sure we are applying the PIP, which in order to make sure it's not creating a lot of pressure on the tissue. And then we place the hybrid. At some point we have some blanching, that's totally fine. We can relieve or we can just wait for a couple minutes and see if this blanching will disappear. Again, this is the maxillary occlusal hybrid. This is the mandibular occlusal view of the hybrid on the mandible. And now it's always important to let the patient know that we have to keep with the oral hygiene instructions, and we have different type of matters that we could use actually whenever in order to have or to maintain a hygienic prosthesis during the time, because it's always important. In these cases we have to make sure that, especially underneath the prosthesis, that the patient is able to clean well. So basically in this cases we have the water pick, we have a special toothbrushes that we use. They can use the mouthwash, they can use actually the super floss that's very important. Make sure whenever what type of tooth paste you're using, because it might be abrasive to certain type of prosthetic options that we could use. Also here what we can use is the interproximal brushes. Those small interproximal brushes will help the patient to access underneath the tissue. In addition, and that depends on the type of space that we have. And in most of the time, we can simply check which one is a better access for the patient and which one the patient should use. And we have different type of companies. One of them is the Tepid that I like to use, which they have some jigs that you can measure how much space you have underneath the contact point or underneath the prosthesis. And this will help you check what is the best interproximal brushes that the patient can use. The super floss is also another one. It's called the super floss because it has a very rigid end at one point. This will help the patient access underneath those implants. And it's always very important to show the implants or to show the patient those implants, where are their positions, so that he knows how many times he should enter the floss and where to clean, which is basically the most common position is around the abutments. So another important thing in that, especially in the maxilla, we can sometimes it's because we should have a good fit so that the patient doesn't have any phonetic problems. We can ensure doing some creating some hygienic spaces. Actually, this will help the patient access and they access those sites in order for the patient to be able to clean around the abutment, so that we prevent plaque accumulation from happening at that point. And this is actually the most important thing, because we don't want plaque to be accumulating around the abutment, so that we don't have any problems around the abutment, any leakage, any inflammation, any bone loss. So it's very important that we should create that. So most of the time we should be aware of what are the things that could happen if we don't respect all of what we talked about today. Actually, we can have some screw loosening. This has to be checked more often. We can have a chipped porcelain or chipped material or veneering material, depending on the type of occlusion that you created. If you didn't adjust the occlusion after delivering the prosthesis, we can have a fractured framework. If you don't respect the space, you can have a screw axis filling material that the material is lost. This is an easy fix. Again, fracture of the opposing restoration, again, if you don't have a respect for the restorative space that we talk about. So it all starts with the planning. If you have a AP spread, if you don't respect the AP spread, you will end up with a larger cantilever. This will create more forces, more chipping, more fracture. So if the patient is a Bruxer, also this is one of the hardest cases, because the patient has to have some kind of protection for the occlusion in order for him to prevent from occlusal forces and from breaking this type of prosthesis. So as a summary for the restorative phases, we should definitely always we should always have a good diagnosis and a good treatment planning, and this is very important. When we are talking about these cases, we have to have, the hardest part here is to have an adequate prosthetic planning prior to surgical execution. We gather all the information, the CBCTs, the position of the teeth. We should have a well-designed denture. This is very important. If the patient comes with a denture that's very old, the denture is already abrasive, we cannot use this as our source or as our reference for occlusion or a reference for the future planning. We should fabricate a newer prosthesis. And definitely this is not the case where we take an alginate impression, send it to the lab send us the denture. No, we should have a border molding. We should do MMR, the maxilla-mandible relationship. We should try the teeth. We should end up with a really well-designed prosthesis. After that, we definitely evaluate the space. We check how much space we need, what type of prosthesis we're going to end up doing. We are going to fabricate the master cast. We're going to, based on that master cast, we take an initial impression. Based on that initial impression, we do something, create a verification jig. This verification jig has to be passively fit. We check that with a Schiffel test. Again, we just put a screw on one side. This whole thing should be seated really well. We place, then after we take the full arch impression, the impression with the custom impression tray, we do the wax rims, and this wax rim, we should set it in MMR, or in centric occlusion, make sure that we are trying the teeth and we are adjusting we're trying the teeth in the patient's mouth, and then we are finalizing this setup. So it's always very important to know what type of bar that you're gonna use. It's always better to use, again, the hygienic bar on the mandible, the wraparound on the maxilla, and then we make sure that the patient is able to clean those areas, or to clean those areas. Why? Because it's important. As you see right here, you can see where plaque will harbor most of the times. It's around the abutments, because if you don't give the patient an easier access to this kind of prosthesis to clean, that is going to create some serious problems. Again, here in this another case in the mandible, at this time, we have 4 implants that were placed, respecting the AP spread, respecting the restorative space. So we removed the provisional restoration that we converted at the day of the surgery. And again, this is 3 months of healing. Now we put the impression, coping on top of these teeth. On top of these implants, or the multi-unit abutments. Then we create the verification jig. And whenever, again, we create the verification jig, keep in mind, you don't want to fill the whole area with the verification jig material because you want to avoid the shrinkage of this material that you're using. So it's always better to kind of section this after you do the whole verification jig. You section it, and then you in a very tiny places, and then you use the verification jig material again to seal those areas. So we take a final impression after removal. Here we just use the custom, we use a regular impression tray, and then we put the soft tissue moulage. As I mentioned, I don't like to connect this soft tissue moulage, and then that's how the master cast will look. And then when we're done with the master cast, now we do another impression coping, just to make sure that we are very accurate with our impression. Again, this is to create now to create a custom impression coping or a custom impression tray that will help us with taking the final impression. And then after we place this in the patient's mouth, we fabricate, we make sure that we have a good fit, passive fit on these cases. We fabricate the screw retained occlusal rim, and then we try the teeth after we have checked the centric occlusion. We check the PMMA, which is basically a temporary, it helps us check, especially if we're going to go with a zirconia hybrid. And then this is the final prosthesis. We place it in the patient. We check if it's hygienic. We make sure we don't have any concavities. If we have extra material, we ask the lab to remove and make sure that, again, it's an easier access for the patient to clean. Again, here we didn't have much AP spread. So basically what we did is, what we created in this case is basically we have a shorter arch. We end up at the premolar, because if we added one more tooth, that's going to put extra strain on, or extra cantilever, extra forces on the distal implant. So it's always important to respect that. So make sure you have an adequate planning, because based on that planning, you have to check where are your implants gonna be, how much reduction you are gonna make, because it's very important to have that from the beginning. We're talking about type 3 prosthesis or here, basic or FP3 prosthesis. Here, in those cases, we are required to remove a lot of bone, especially in the metal acrylic places. So those cases, we should always keep in mind, you should always keep in mind that we should always not push for such cases. We have an option for an FP1 prosthesis. Yes, it's more expensive, but it saves the bone, because once the bone is gone, it's gone. You should always think that this patient, think about how old is this patient. If this patient is this young, like between the 30s and the 40s, and now he's having to, you have to reduce like 10 millimeter of bone to place all-on-4, there has to be some ethical matters here. Ethics should matters actually, because if anything happened, you are subjecting these patients to a lot of future problems, actually, especially in the mandible. So we have to always keep in mind the importance of maintaining a well hygienic prosthesis, and also trying to avoid any complications from happening by having adequate planning from the beginning to limit the amount of prosthetic and surgical prosthetic and implant complications that could happen afterwards. We should maintain a good keratinized, good hygienic tissue, or the keratinized tissue around the implants. This is always recommended. If we don't have enough keratinized tissue, soft tissue grafting is always considered. The intaglio surface is either flat or convex. It should never be concave, because that's going to make it harder for the patient to clean. And at the end, we have to have ensure adequate posterior bone reduction. Most of the time, because we're placing our implant between the intramental foramen, we forget that we have to make sure we have to reduce all the way to the back. This will limit the amount of prosthesis, especially if you're trying to have a shorter or a moderate cantilever there. This could limit your amount of interocclusal space that you could have. So this is a very, if you're not very familiar with full arch cases, you have to make sure that you have to have more training on planning, more training on surgical steps, on prosthetic steps, because this will help once the bone is gone. Again, as I mentioned, it's gone. Once the implants are placed, you have no comeback unless you take those implants again, which is more, this is more traumatic for the patient. And then once the prosthesis go in, most of the time we're aiming for longevity, we're aiming for less complications, we're aiming for less problems. I think with a night guard also at the end for the final prosthesis, this will help with the maintenance, especially if the patient is a Bruxer. Make sure we're adjusting the occlusion on that really well. And then with that, I want to thank you for your attention. Keep in mind, this is just an overview of the final steps, but what we should care more about is the planning in such cases. In planning, I repeat that 3 times. Why? Because once we place the implants, once we reduce the bone, once we don't have accurate planning, this will lead to some serious problems. And the least that could happen is the loss of the material in the screw access channel. And the worst that could happen is the chipping of the whole prosthesis or the final prosthesis, and definitely implant loss or bone loss around the implants. With that, I want to thank you so much for your kind attention, and I open the space for questions if you have any.
Yeah, thank you so much, Dr. Basma. Well, with this, we have come to the end of this very educative and interactive session. I'm sure the audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us. I would also like to thank our educational partners, FDC Limited, and CME partner Spirent Communication for conducting of the program. Happy weekend to all. We meet next again.
Thank you so much.